Let me paint you a picture. You are watching a show, or you are on a work call, or you're doing absolutely nothing, just sitting there existing. And then you realize your fingers are already in your hair, and you have been pulling, and you do not remember deciding to do that. You just are doing it. And then, depending on who you are, one of three things happens. You stop and feel embarrassed and kind of confused. Or you don't stop because stopping feels oddly worse than continuing. Or, and this is the one I find most fascinating from a science standpoint, you feel a strange sense of relief. Like something inside you finally exhaled. That is not you being strange. That is a documented, classified, researched neurological phenomenon. And today, we are going to understand it completely. I am Ada. This is Nwanyi. And we are about to go deep into the brain science of trichotillomania. Why it happens, who it happens to, why the shame around it is particularly loud for Black women, and what science says you can actually do about it. Milo and Luma are here too.
As always. And I just want to say up front, if this is hitting close to home, you are in the right place. No judgment, none. We are just here to understand.
Affirmative. The goal of this episode is comprehensive understanding of a frequently misrepresented disorder. I will be providing the neurological and clinical framework. I have been told that I should also, quote, make it feel like I care. I am attempting that.
That is genuinely the sweetest thing she has ever said. Okay, let us start with what this actually is. Trichotillomania. If you just tried to say that out loud and stumbled, same. It comes from the Greek words for hair, pulling, and madness, which is arguably an unfortunate naming choice, but we will leave that alone. Officially, trichotillomania is defined as a body-focused repetitive behavior disorder, characterized by recurrent, compulsive urges to pull out hair from the scalp, eyebrows, eyelashes, or other parts of the body. It is classified in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, the DSM-5, alongside OCD, body dysmorphic disorder, excoriation disorder, and hoarding disorder. That whole cluster is called the Obsessive-Compulsive and Related Disorders chapter. But here's the thing that immediately gets interesting. Just because it is in that chapter does not mean it works exactly like OCD. And understanding the difference is actually key to understanding why it is so hard to treat.
Correct. In classic obsessive-compulsive disorder, there is a defined sequence, an intrusive thought or obsession, then a compulsion performed to reduce the distress caused by that thought. In trichotillomania, this structure is frequently absent. Research led by Dr. John Grant at the University of Chicago found that approximately 1/3 of people with trichotillomania describe the pulling as rewarding rather than as relief from distress. This positions it functionally closer to an addictive behavior than an anxiety-driven compulsion.
So, it is like a compulsion without the obsession. Dr. Grant actually described it exactly that way, a compulsion without an obsession. It is the flip side of OCD, which is a completely wild way to think about it.
So, let me translate that for the humans in the room. Some people pull because they are anxious, and the pulling makes the anxiety stop, which is what most people assume. But some people pull because it feels genuinely good, not in a way they can explain or justify, just good, like an itch being scratched or a puzzle clicking into place. And that is somehow even harder to explain to someone who has never experienced it. Because how do you say out loud, I pull my hair because it feels nice, and I cannot stop, even though I am going bald in that spot?
You said that exactly right. And the shame of the second version is often worse, because at least anxiety feels like an acceptable explanation. Saying it feels rewarding sounds like something is wrong with you morally, not neurologically. but is not. And we are going to prove it, right after we tell Luma to please explain what is happening in the brain.
The neurological basis of trichotillomania involves the corticostriatal circuitry, which is a system connecting the cortex, which governs thinking and decision-making, with the striatum, which governs habit formation, motivation, and reward processing. Under normal conditions, this system functions to help the brain automate repetitive tasks that have been associated with positive outcomes. Walking is an example. Brushing teeth is another. The brain streamlines repeated behaviors that have yielded reward into automatic loops. This is efficient and adaptive under most circumstances. In trichotillomania, researchers hypothesize that the pulling behavior becomes encoded within this loop as a reward-associated action. Neuroimaging research, including studies using single-photon emission computed tomography, has shown altered activity in the frontal regions and corticostriatal pathways in individuals with trichotillomania. The pulling becomes, at a neurological level, automatic. The brain does not consult the conscious mind each time. It simply executes.
Okay, so the brain basically does the same thing it does when you learn to drive. At first, you are thinking about every single action: signal, brake, check mirror, turn. And then one day you look up and you have driven to the wrong location entirely because your brain went on autopilot. Trichotillomania is that. But the thing the brain is automating is pulling hair that said, "This is worth repeating."
Which is genuinely so much more sympathetic than I think most people imagine. Because we hear hair pulling and we think, why don't you just stop? But you do not say that to someone who automatically hits their brakes when they see a red light. You do not tell someone to just stop blinking. The brain has encoded this. It is running a program.
And what makes it even messier is that the trigger can be almost anything: boredom, stress, concentration. Some people pull more when they are deeply focused on something. Some people pull when they are completely unstimulated. Some people have a tactile preference. They are looking for a specific texture of hair. Some people pull and immediately release. And some people examine what they pulled. The presentations vary so much that two people can both have trichotillomania and describe totally different experiences.
This variability has led researchers, including Dr. Grant's team, to suggest that trichotillomania may not be a single etiology disorder, but a spectrum with multiple neurological subtypes, each of which may respond best to different treatment approaches. A clinician who does not account for this may apply a treatment designed for one subtype to a patient with a different subtype and observe limited results. This is one reason the disorder has historically been difficult to treat uniformly.
And there are no FDA-approved medications specifically for trichotillomania. None. Which I found genuinely alarming when I researched this. Dr. Grant himself has publicly described trichotillomania as, and I am quoting him here, a forgotten stepchild among psychiatric disorders. Nobody has really invested in it, which means millions of people are carrying this thing in silence without much support. So who has this? The point prevalence, which is the estimated percentage of people who have it at any given moment, sits between 0.5 and 2% based on current research. A large 2020 survey of 10,169 adults in the United States found that 1.7% of respondents met criteria for current trichotillomania. That is roughly equal between men and women in that particular study, which is notable because older data suggested a 4-to-1 female-to-male ratio in adults. At 1% prevalence, the estimate is that approximately 2.5 million people in the United States have trichotillomania at some point in their lives. That is a lot of people pulling their hair out, quietly and alone.
And most of them are not telling anyone. That is the part that keeps sticking with me as we put this episode together. The shame is so loud that most people go years without mentioning it to a doctor, a friend, a therapist, anyone. They just manage it. They develop systems to hide it. And they feel like the only person on earth experiencing it.
The hiding is its own whole thing. Research has documented that people with trichotillomania develop elaborate concealment strategies, wearing hats, head wraps, wigs, choosing hairstyles that disguise patches, avoiding windy days, avoiding hair salons, avoiding sleepovers, avoiding anything where the cover might come off, literally. And the disorder typically begins between ages 10 and 13, right at the beginning of adolescence. Some young children pull and stop on their own, but for those who continue into adolescence and adulthood, it tends to become chronic. The average age of onset differs by gender. One study found females begin on average around age 14.8, while males begin around age 19.
Comorbidity rates are significant. A 2020 study in the journal Psychiatry Research found that 79% of people with trichotillomania had at least one co-occurring mental health condition. The most common comorbidities were anxiety disorders, depressive disorders, OCD, PTSD, and ADHD. This is clinically important because treating trichotillomania in isolation without addressing co-occurring conditions is likely to yield incomplete results.
79%. That means the majority of people who have this are also dealing with something else. So it is not just the loop in the brain, it is the loop sitting on top of anxiety or depression or ADHD. And that is a lot. That is a genuinely heavy load. Okay. Now I want to talk about something that I think is deeply important and deeply underexplored in the research, which is what this disorder means specifically for Black women. Hair is not just hair for us. And I say that not as a cliche, but as a documented, studied cultural reality. Black women exist in a context where hair carries explicit messages about identity, professionalism, beauty standards, heritage, and social belonging. This has been researched, legislated around with the Crown Act, and lived by every Black woman in this country. So what happens when a disorder strips you of control over that hair?
What happens is that the experience is not just neurological. It is cultural, it is relational. It is tied to every message you have ever received about what your hair is supposed to be, supposed to look like, supposed to mean. And when you are pulling it out in patches, you are not just experiencing distress about the hair itself. You are experiencing distress about what losing that hair means in the context of your whole identity.
In 2009, Dr. Angela Neal Barnett and her colleagues at Kent State University published a study specifically examining trichotillomania in African American women. It was one of the first studies to even try to account for cultural context in trichotillomania research. They found that TTM severity and impairment were positively correlated with anxiety symptoms, and crucially, that cultural messages about hair influenced both the disorder and the anxiety around it. One of the things they noted in the study was that many participants felt they were the only person in the world experiencing this. The shame, the guilt, the isolation were so pervasive that the decision was made to conduct the study by phone interviews rather than in person, specifically to give women a layer of anonymity so they would actually participate.
That detail stops me every time. The study was designed around the shame. Because the shame was so thick, they could not get people to show up in person and talk about it. Think about what that means for the thousands of women who never saw a study like that and never found their way to a professional who even knew the word trichotillomania.
The academic literature confirms that trichotillomania remains substantially under-researched in African American communities specifically. The study by Dr. Neil Barnett and colleagues noted that cultural factors in trichotillomania research have been, to use their language, virtually ignored. Subsequent research has built on this work, but the gap remains significant. This means clinical guidance for Black women with trichotillomania often does not account for the specific cultural dimensions of their experience.
And I want to be precise about what that looks like in real life, because I think precision matters here. A Black woman seeking treatment for trichotillomania is already navigating a mental health system that has historically underserved her. She is then asking for help with a disorder that most general practitioners have never heard of. She is trying to describe something that feels tied to her hair, which carries a layer of cultural specificity that her provider likely has no framework for. And all of this is happening while she is ashamed of herself for something she cannot control. That is not a small thing. That is a systemic failure wearing the face of a personal struggle. Let us talk about shame specifically, because I think it deserves its own moment. Shame says, you are broken. You should be able to stop this. Something is wrong with you that is not wrong with other people. And shame, unlike guilt, does not motivate repair. Guilt says, I did something wrong and I want to fix it. Shame says, I am something wrong and there is nothing to fix.
And that distinction matters so much in a mental health context, because guilt about the behavior might motivate someone to seek help. Shame about the self keeps people hidden. It keeps people quiet. It keeps people pulling in the dark and covering the evidence and feeling more and more isolated.
Professor Claire Mackay, who is a professor of imaging neuroscience at the University of Oxford, has spoken publicly about her own experience with trichotillomania since childhood. She described the toxic shame of pulling your own hair and the message we receive and give to ourselves. Why don't you just stop? She pointed out that this message, directed at compulsions or addictions of any kind, does not reduce the behavior. It increases the shame. And more shame from most people means more pulling.
This is consistent with neurological data. Stress and shame activate cortisol responses, which increase the urgency of self-soothing behaviors. For an individual whose brain has encoded hair pulling as a soothing behavior, stress-induced shame is therefore likely to increase the frequency of pulling rather than reduce it. Telling someone with trichotillomania to simply stop is functionally counterproductive at a physiological level.
Counterproductive at a physiological level. Luma with the clinical precision that I need every day of my life.
The point is, this is not a character flaw. It is not a reflection of your discipline or your intelligence or your worth. Your brain learned something. Your brain is executing that thing, and you deserve actual support for that, not a chorus of just stop it.
Okay, so what can you actually do? Because I do not like ending conversations in the problem. Let's talk about solutions. The treatment with the strongest evidence base for trichotillomania is habit reversal training, or HRT. HRT is a behavioral therapy approach that works by helping a person become more aware of when and how they pull, and then training a competing response, a different behavior that they can perform in the same moment when the urge to pull arises, something incompatible with pulling, so the two behaviors cannot happen at the same time. A review published in Frontiers in Behavioral Neuroscience found that HRT demonstrated a large effect on reducing pulling behavior compared to baseline across multiple randomized controlled trials. It is considered the first-line behavioral treatment for trichotillomania in both youth and adults.
A combined approach of habit reversal training with acceptance and commitment therapy, known as ACT, has also demonstrated significant efficacy in multiple randomized controlled trials. ACT contributes a framework for relating differently to the urge itself rather than simply suppressing it. Rather than fighting the urge, the person learns to observe it, acknowledge its presence, and choose a different action without requiring the urge to disappear first. Research has shown that reductions in experiential avoidance, which is the attempt to suppress or avoid internal experiences like urges, are correlated with reductions in pulling severity.
So the goal is not to make the urge stop existing. The goal is to change your relationship with the urge so that it no longer automatically wins. Which, when I heard that, I actually found incredibly freeing. Because I think a lot of people approach this with the belief that they have to feel completely different inside before they can behave differently on the outside. ACT says, you do not have to feel different. You just have to act differently, one moment at a time, while still feeling the urge.
That is a philosophy I think applies to a lot of things in life, honestly. But for this specific thing, the fact that there is research behind it, multiple randomized controlled trials, means it is not just a feel-good idea. It is a documented path forward.
Long-term outcomes for HRT show that treatment gains are generally maintained for several months post-treatment. There are also some pharmaceutical approaches being studied, though as I mentioned, nothing is FDA approved specifically for trichotillomania. N-acetylcysteine, which is a supplement that affects glutamate regulation, has shown some promise in research trials. Clomipramine, an older antidepressant, has shown more evidence than SSRIs for trichotillomania specifically. But medication decisions are always conversations to have with a qualified provider.
I want to add one clinical note. Given that 79% of people with trichotillomania have co-occurring conditions, treatment planning should ideally address the full clinical picture. A provider who treats only the hair pulling and does not account for comorbid anxiety or ADHD may see limited long-term results. Integrated treatment is more likely to yield durable outcomes.
If anything in this video has landed for you or for someone you love, here's where I want to land this plane. The first step is just naming it. Trichotillomania, a real disorder with a real name, with real research behind it. You are not making this up. You are not dramatic. You are not uniquely broken. You are a person with a brain that learned a loop it should not have learned. And loops can be interrupted.
The next step is finding someone who actually knows what this is, which takes research because, as we have established, a lot of healthcare providers have not been trained in it. You can look for therapists who specialize in body-focused repetitive behaviors, BFRBs, or in OCD and related disorders. The TLC Foundation for Body-Focused Repetitive Behaviors is a real organization that has a therapist directory. That is a verified, legitimate place to start.
And if you are a Black woman carrying this, I want to specifically say, look for a provider who can hold the cultural context of your experience. Not just the neurology, all of it. You deserve that. Your hair is part of your story. Your treatment should know that.
Trichotillomania is classified as a treatable condition. The evidence for behavioral intervention is robust. The shame is not clinically necessary. It is not useful. And it does not have to be permanent.
That is a wrap on this one. Thank you for being here with us. Subscribe if you want more deep dives like this one. And join the circle at Nwanyi.com. Leave a comment if something in this video hit different. We read them. See you next time.
And remember, soft but sovereign, always.
This has been informative. I believe I also felt something. I will analyze that further.
And there she is. Bye, everybody.